Vijay Bhaskar, really thank you for the kind invitation and more than generous introduction. And as Ishwar mentioned, we were really fortunate to have been together in medical school at Cardiology Medical School in Warangal. We met, I believe, as Ishwar reminded me, at Apollo Hospital for their inauguration of their cyclotron, which I think has been more than 15 years ago now. So thank you so much. So my topic today is to discuss about advanced imaging for the non-invasive diagnosis of transthyretin cardiac amyloidosis. These are my disclosures. I have several grants for the topic of amyloidosis, but I'll try to keep my talk unbiased. So this is an overview of what I'll be talking about. I'll start off with a little overview about amyloidosis, then discuss the various imaging targets in amyloidosis, then identify diagnosis using imaging, then discuss the various diagnostic criteria, quantitative imaging with technetium 99 and P by P, then prognosis and response to therapy is something that we may not have time to go over in this talk. We may cover that in question and answer session, and then I'll give you some concluding remarks. So to start with, the first question is, why are we interested in this so-called rare disease? Why is this discussion on cardiac transthyretin amyloidosis timely in 2021? The reason is this disease was once felt to be rare and untreatable and highly fatal, but we now recognize that it is highly underdiagnosed. It causes heart failure with preserved ejection fraction in almost 10 to 15% of older adults with HFpEF, and it is most importantly treatable. Why is there an interest from the imaging side? As you will see later, this was a diagnosis that was previously only possible by biopsy, particularly endomyocardial biopsy. We can now diagnose this disease using imaging. So I think the setup of recognition that this is underdiagnosed, the availability of treatments, the possibility of non-invasive imaging using radionuclide methods as well as echocardiography and magnetic resonance imaging have really set the perfect stage for why this disease is being now discussed. So what is amyloidosis? This is actually a series of group of disorders which result from protein misfolding. A number of diseases are felt to be related to amyloidosis. Alzheimer's disease, as we know, diabetes, fungiform encephalopathies, and systemic amyloidosis, which is the topic for our discussion today. The two major forms of amyloid fibrils that deposit in the heart, the first one is called the immunoglobulin light chain or AL amyloidosis, and the second form is called the prealbumin or transthyretin cardiac amyloidosis. So the immunoglobulin light chain amyloidosis is a bone marrow pathology. It's a bone marrow problem. It has a rapidly progressive clinical course. It's treated by chemotherapy for our treatment of the bone marrow. If untreated, median survival is about 6 months. So this is one of the more aggressive forms of disease. The other disease is called the transthyretin amyloidosis. This exists in two major forms. One is the wild type form of aging. And the second is an autosomal dominant mutation. And this mutation, many different mutations have been described. One of the mutations, the V122I, has been found in about 4% of patients of African American descent. The clinical presentation is very similar to AL amyloidosis with heart failure, neuropathy, both heart failure and neuropathy, but this disease is slightly slowly progressive compared to the light chain form of disease. How do you treat this? The treatment is now using novel therapies. There's one drug that's approved for treatment of this condition, and that stabilizes the transthyretin protein. Before this became available, the hereditary form of disease was treated by liver transplant. The reasoning is liver produces the transthyretin protein, which misfolds and deposits as fibrils in the various organs. So liver transplant hopefully is now no longer needed because of the new treatments. If untreated, median survival is only 7 years after onset of heart failure. Remember, some of these patients, particularly the hereditary form of disease, may manifest their symptoms in their 40s and 50s. So median survival of 7 years is really bad in these patients and deserves accurate recognition and therapy. So therefore, it's not only important to diagnose this disease, but it's also important to type the amyloid fibril as light chain or transthyretin so that we can administer appropriate therapy. If it's light chain, we administer chemotherapy. If it's transthyretin form of amyloid, we could use either a TTR protein silencer in the mutant or hereditary forms and a TTR protein stabilizer in the wild type form of disease. Biopsy was originally the only way to diagnose this disease. It still remains essential for the light chain form of disease and has a high sensitivity, about 84%, particularly using fat pad biopsy. But for ATTR amyloidosis, fat pad biopsy has limited sensitivity. For the hereditary form, 45%, for the wild type, 15%. It's a very low yield to biopsy the fat pad. Moreover, expertise is required to interpret the biopsy, and there's now new knowledge that we'll discuss that typical features on radionuclide imaging can almost definitively diagnose transthyretin cardiac amyloidosis, eliminating the need for endomyocardial biopsy. Currently, endomyocardial biopsy is primarily reserved for patients with equivocal findings or for patients with discordant clinical and imaging findings. So what are the imaging targets in cardiac amyloidosis? So here's a schematic showing the heart, the left ventricle here and the right ventricle here. And the insert here, you see cardiomyocytes, and this light pink is the extracellular space between the cardiomyocytes. This is a normal myocardium. A variety of cardiovascular diseases can result in wall thickening. So left ventricular hypertrophy, which is resulting from myocyte hypertrophy, can be seen in high blood pressure or in aortic stenosis or conditions where the left ventricular afterload is increased. The other reason for wall thickening, which typically impacts both left and right ventricles, is an infiltrative pathology. So in this case, shown in blue is the infiltrative process, which expands the extracellular space, increases wall thickness, typically both left and right ventricular wall thickness. Echocardiography and cardiac magnetic resonance imaging are both excellent techniques to image the structure of the heart, to look at the wall thickness of the left ventricle, right ventricle, to measure myocardial mass and changes with treatment. More importantly, cardiac magnetic resonance imaging, particularly using gadolinium-enhanced contrast, can allow us to measure the extracellular space, the ECV. And this expansion of extracellular volume is pathognomonic feature of cardiac amyloidosis. However, what we'll know is ECV can be expanded from fibrosis or from infiltration from any pathology. It could be amyloid, it could be non-amyloid related infiltration. So the most specific way to image amyloid fibrils, which are the primary pathology in this disease, is to use radionuclide tracers which bind to amyloid fibrils. So we have a number of SPECT tracers as well as SPECT-based tracers that can target the amyloid fibrils and provide a specific signal of amyloidosis. So how do we diagnose cardiac amyloidosis? A lot of times these patients initially present with heart failure, so echocardiography is the typical first test in these patients. Echocardiography, here's the left ventricle, left atrium, right ventricle, right atrium. This is the 4-chamber view that you may be familiar from cardiac MR. The same thing on echo. You see bright and sparkly myocardium, thickened ventricles, thickened interatrial septum, thickened valves, small pericardial and pleural effusion sometimes, and this classical pattern of global longitudinal strain. So global longitudinal strain is a technique where you follow the speckles, the ultrasound speckles on the heart muscle, and this is a sensitive marker of systolic ventricular dysfunction, which can be abnormal before overt decline in LV ejection fraction. In cardiac amyloidosis, this classic pattern of apical sparing has been described where the apical myocardium contracts better than the mid and basal myocardium, resulting in this cherry on top appearance of global longitudinal strain. Furthermore, amyloidosis is classic infiltrative pathology. So restrictive filling pattern on mitral infradoppler and very reduced flow velocities, myocardial tissue velocities on the mitral annular Doppler signal are pathognomonic of this disease. Rarely, you might see patients who have left ventricular outflow tract obstruction, which can mimic hypertrophic cardiomyopathy, both on echocardiography and magnetic resonance imaging. And this is something to remember in the differential diagnosis of these cases. What about MRI? MRI can be extremely helpful in these cases. A characteristic inversion time scout has been described. And here on bottom is what is normally expected when gadolinium contrast is administered and you take an inversion time recovery scout. When you look at this scout in a normal patient, you see that the blood pool nulls at an earlier time compared to the myocardium. In amyloidosis, this is completely inverted, where you see that the myocardium nulls at an earlier time before the blood pool nulling. And this is a classic finding that has been described and found to be specific marker for amyloidosis. Conventionally, MRI can provide excellent quality structural imaging. All the features seen on echocardiography can be seen on MRI. Thick ventricles, interatrial septum, pericardial pleural effusions, atrial enlargement, right ventricular thickening, all of these can be seen. In addition, you can look at native T1 imaging to look at myocardial tissue characteristics, which provides a signal both from the cardiomyocyte and the extracellular space. Extracellular volume imaging, looking at pre and post gadolinium imaging, has emerged as one of the classic features with expansion more than 0.4 described in advanced cardiac amyloidosis. Late gadolinium enhancement has been classically described. This is diffuse. It can be subendocardial, transmural, mid-myocardial. It can affect the right ventricle. It can affect both atrial walls as well. What we know from previous studies is LGE is a late manifestation of amyloidosis seen in advanced disease, whereas ECV expansion can be more sensitive and can detect earlier disease. So right now, because of the availability of treatment, there is an increasing focus on early disease detection so that these patients can receive appropriate therapy. The challenge with echocardiography and magnetic resonance imaging is that none of the structural imaging features can definitively distinguish amyloidosis from non-amyloid thickening of the left ventricle. So this is where radionuclide tracers have an emerging role. We have a number of SPECT-based compounds that are now currently widely available and used for imaging TTR cardiac amyloidosis. We use PYP in the US, and I know in India as well. In Europe, a lot of folks use DPD or HMDP. I-123 SAP is a pan-amyloid imaging SPECT tracer that has limited availability globally. It's been used in UK and some of the European countries. Heparin reactive peptide P5+14. This is an emerging radio tracer. We're doing some work with it with the I-124 labeled positron emission tomography. We will wait for the results of this. The amyloid PET compounds, which were originally developed for imaging beta amyloid or Alzheimer's disease, have all been studied in imaging cardiac amyloid, and results demonstrate that these agents can nicely image both AL and ATTR cardiac amyloidosis. Existing studies suggest that these tracers cannot distinguish AL from ATTR. The bone avid compounds, for some reason, tend to have a greater affinity for TTR amyloid and show mild or absent signal in AL amyloid. Some patients with AL amyloid, about 20 to 25%, do demonstrate high grades of uptake of bone avid compounds, and we're still trying to understand why that may be the case. So the use of bone avid scintigraphy to image cardiac amyloid is not new. This has been reported more than 40 years ago, and initially using planar imaging showing that in patients who underwent bone scans, myocardial uptake of tracer indicated presence of cardiac amyloidosis. What was not known at that time in the 80s is that this tracer is more specific for TTR than for AL. Therefore, what happened was in the 90s and in the early 2000s, the results from various studies showed high sensitivities where the patient cohorts included more transthyretin patients and low sensitivities in studies where there were more AL patients included. Because of these varied results, it was not recognized and it was felt that these agents are not good for imaging amyloid. In the early 2000s, Dr. Rapezzi and colleagues in Europe, in Italy, recognized that the bone avid tracers are more specific for TTR, and that has led to a drastic change in application of this imaging in amyloidosis, and now it's used as a clinical tool in most laboratories. So what is the imaging protocol? This is how, this is a generic protocol. You can give 10 to 20 millicuries of PYP, DPD, or HMDP intravenously, wait 2 to 3 hours. You could get a planar image, a SPECT image. And if you're using SPECT CT, I would recommend that SPECT CT is the best technique to image this agent. What are we doing in our lab? We are using 20 millicuries, 2-hour wait time. We are not performing planar image. We are performing a dedicated SPECT CT scan using a CZT SPECT CT scanner. Once you get the images, you can review them and interpret them visually using a semi-quantitative visual grade. Grade 0 is no uptake with normal bone uptake. So remember, you do need to see bone uptake. Grade 1 is myocardial uptake present, but less than rib uptake. Grade 2, myocardial uptake present and equal to rib uptake. Grade 3, myocardial uptake present, it is greater than rib uptake, and rib uptake may be attenuated, mild or absent. So on top are SPECT images, on the bottom are SPECT CT images showing the same, and this is how we grade them. So previous studies have shown that grade 2 and grade 3 uptake of bone avid tracers is highly diagnostic and accurate for identification of transthyretin cardiac amyloidosis. Grade 0 excludes amyloidosis. Grade 1, we are still trying to understand whether this could be useful to identify early forms of disease. This is a seminal study of nearly 1,500 patients with nearly 400 of them with endomyocardial biopsy. It comes from 8 major amyloidosis centers from 5 international countries. The results of this study show that if you look at grade 2, grade 3 PYP positivity, and you exclude AL amyloidosis by looking at serum free light chain assay, serum and urine immunofixation electrophoresis, then this patient, the scan result is nearly 100% specific to identify transthyretin cardiac amyloidosis. However, note that if you look for grade 2 and grade 3, it is only 72% sensitive. So the detection rate is low, but it's highly specific. What about if you look at any PYP positivity as indicating of disease, then you'll see that the specificity goes down to 78%, sensitivity increases somewhat. But at this point, this test is best utilized with the characteristics described in the right bar, because this allows us to avoid endomyocardial biopsy, and therefore the recommendation is to go with grade 2, grade 3 positivity, exclude AL amyloidosis, and in those cases, we are nearly certain that this is transthyretin cardiac amyloidosis and treatment can be initiated. So what's the added value of SPECT, SPECT-CT, and PYP quantitation? Addition of SPECT allows us to distinguish blood pool activity from myocardial activity. The measurements can be more reliable, and it is possible that pre and post treatment may be better assessed using SPECT-CT. Absolute quantitative measurement is possible using some of the latest generation SPECT-CT scanners, looking at estimation of whole heart amyloid burden, similar to tumor metabolic volume in oncology. Of course, absolute quantitation makes possible radiomics approaches, which can allow us potentially to detect change or response to therapy. However, it's important to recognize that PYP, DPD, HMDP, all of these tracers are specific for amyloid, but don't necessarily distinguish AL from ATTR amyloidosis. So I just wanted to share a few cases with you. So here's the case of a 52-year-old man with progressive heart failure. His sister died of transthyretin cardiac amyloidosis at 52 years of age, diagnosed at Mayo Clinic, which is one of the major amyloidosis centers in the US. He underwent echo, nuclear stress test, coronary angiography, and a cardiopulmonary stress test. Then finally, he presented to our institution where we performed a technetium 99M PYP SPECT CT. And here you can see diffuse uptake. Left and right ventricles is in heart failure with bilateral pleural effusions. Here's his echocardiography. Thickened ventricle, bright and sparkly myocardium, really massively thickened ventricle. Unfortunately, he did not survive, went on to autopsy, and autopsy confirms echocardiographic findings and the sections, histology on sulfated Alcian blue staining. All the blue green represents amyloid and the yellow represents cardiomyocytes. And again, you can see diffuse myocardial amyloid deposition in advanced disease. This is the space we were in maybe 10 years ago, and this has changed. We now are able to use imaging at an earlier stage and detect early disease to hopefully prevent this outcome with the available treatments. What about this case? Here's a patient who has high blood pressure. Echo in 2011 showed reasonably normal wall thickness. 2018, wall thickness increased. This is despite adequate blood pressure control. So the doctor was concerned that this could represent an additional infiltrative process, referred the patient for PYP, and here's grade 3 uptake. So early diagnosis. So early diagnosis is feasible if you think of amyloid. Here's an example of a patient where amyloidosis was suspected based on echo and based on MRI and referred for PYP imaging. Okay, there you go. So the PYP scan was completely negative. You can see the ribs, but nothing in the heart. Okay, both echo and MR confirm classical features. This patient went on to have further evaluation. He was diagnosed with light chain cardiac amyloidosis. Floor beta PET CT confirms the presence of amyloid in the heart. Again, remember that a negative PYP scan does not exclude all forms of amyloid, and it can still indicate the presence of light chain cardiac amyloidosis. Here's a patient who had prostate cancer with heart failure. His echo and MRI were typical for infiltrative pathology. His DPD scan, which is, MDP scan, which is what we use for bone scanning, was completely negative, nothing in the heart. So the team had come back to us with a question: how confident are we that this negative scan represents absence of amyloid because his echo and MRI were consistent with an infiltrative pathology? So we repeated the PYP scan in this patient and found that he had significantly positive PYP uptake, grade 3 uptake in the myocardium, confirming transthyretin cardiac amyloidosis. So the teaching point here is that a negative MDP does not exclude ATTR. Here's an example of a patient where we performed early imaging and late imaging. So on the early imaging, you see myocardial uptake, but no bone uptake. This is the clue that this was performed too soon. So this is images from the same patient at 3 hours showing rib uptake and myocardial uptake, suggesting that this is accurate. The reason A can be challenging is because PYP, DPD, and MDP are blood pool tracers. And early on, within the first 15 minutes, you can image almost like a MAGA scan. You can image blood pool activity. So very, very important to look for rib uptake and only interpret the myocardial signal at a time point where you see adequate rib uptake. SPECT CT, if available, is really important. Here's a patient where you see apparent myocardial activity in relation to rib. It's equal to or less than rib activity. When you look at SPECT, you feel like there may be some myocardial activity here with the blood pool cavity. But SPECT CT confirms that what you're seeing here is actually blood pool and the myocardium is completely negative. So excellent example of why SPECT CT, if available, is critical to avoid misdiagnosis of this as positive. Here's an example of a patient with grade 3 PYP activity. Heart to contralateral ratio is high. PYP activity is grade 3. However, subsequent evaluation for light chain amyloidosis confirmed that this patient had AL or light chain cardiac amyloidosis. Very important, exclude AL amyloidosis in all patients before calling it cardiac amyloid based on a PYP scan. Why is this important? Because AL amyloidosis, as we discussed earlier, if untreated, has a median survival of 6 months. So this is a diagnosis you don't want to miss. You don't want to falsely call this as TTR amyloid because the patient may be dead in 6 months. Here's an example taken from a publication, actually. Here they looked at patients with a hereditary form of disease. And here's the C11 Pittsburgh V compound PET. And here's DPD and healthy volunteers. So the key points on this study are that certain patients who have full length or fragmented fibrils, right? In the full length fibrils, you can have DPD negative, but PIB positive. Whereas in fragmented fibrils, both DPD and C11 PIB are positive. The moral of the story is certain forms of mutations, TTR mutations, with full-length ATTR fibrils may be missed by bone avid scintigraphy, but identified by PET. So remember, to detect certain forms of hereditary TTR amyloidosis. So the next point I wanted to make is quantitation of PYP using advanced SPECT CT scanners, maybe the next frontier in these patients, both for early diagnosis.
You know, I have hot classes. అయ్యో తప్పకుండా వన్ బై వన్ మీ పేరు చెప్పండి.
నా పేరు రుచి, నేను సుచి. ఇప్పటికి ఇంకా నా వయస్సు నిన్న 16.
16 ఒక్కట్లా అమ్మ 16 రెండురా. 16 మూడు లేసిన తప్పులేదు సార్. 16 మూడు లేసిన తప్పులేదు సార్. ఏం కావాలి? హాస్టల్లో రూమ్ కావాలి. నాకు కూడా హాస్టల్లో రూమ్ కావాలి. నీకైతే అసలు లేదు.
Okay. Sorry about the interruption. So I just wanted to summarize the points of bone avid scintigraphy, suggesting that this is a sensitive but highly specific marker for the diagnosis of ATTR cardiac amyloidosis, provided a plasma cell dyscrasia is excluded and typical imaging features are present on echo or magnetic resonance imaging. Remember the caveats. Delayed imaging and SPECT imaging, SPECT CT, if available, are essential to avoid mistaking blood pool as myocardial activity. Certain hereditary forms of disease may have low sensitivity. AL amyloidosis needs to be excluded in patients with any grade PYP uptake if echo and MRI are suggestive of cardiac amyloidosis. MDP has a low sensitivity for ATTR cardiac amyloidosis. At this point, we believe that visual grade is not adequate to assess response to therapy. Visual grade doesn't appear to provide any prognostic value, and the significance of visual grade 1 is unknown and remains to be established. For these reasons, we think quantitation may be helpful. And here's a study where we looked at a cadmium zinc telluride-based SPECT CT scanner and looked at quantitation using SUV-based metrics, as well as looking at percent injected dose and measuring SPECT-based measures of cardiac amyloid activity. So what we found in this study is that when you look at cardiac amyloid activity as an integrated measure of activity in the entire left ventricle, it increased with visual grade. It was linearly related to left ventricular mass index as a surrogate for amyloid, and it was linearly and strongly related to extracellular volume in a very small number of patients. Most importantly, when we look at the relationship to predict LV mass index, all of these metrics appear to be statistically significant in predicting left ventricular mass index as a surrogate for amyloidosis. Here are a few examples from that study. Patient with grade 2 myocardial uptake equal to rib uptake. SPECT CT showing clearly myocardial activity, no blood pool activity, right ventricular activity, and you can get quantitative measures. Here's grade 3, intense myocardial activity, which is more than rib activity. And you can see SUV max is higher, SUV mean is higher, and all the other metrics are also increased. So the societies have come together. ASNC, American Society of Nuclear Cardiology, has collaborated with multiple other societies and put out guidelines for both standardized imaging of cardiac amyloidosis, as well as provided diagnostic criteria and appropriate utilization of imaging in cardiac amyloidosis. So the experts in these guidelines have suggested that ATTR cardiac amyloidosis can be diagnosed without endomyocardial biopsy if there is grade 2, grade 3 PYP myocardial uptake, if you exclude a clonal plasma cell process, and if you include the presence of typical imaging features on echo or magnetic resonance imaging. Who to test for amyloid? These are the groups that the experts felt could benefit from amyloid imaging. Older adults, particularly those with HFpEF or LV thickening, if African American, HFpEF and LV thickening in all others, low flow, low gradient aortic stenosis, heart failure with peripheral sensory neuropathy, unexplained, known or suspected hereditary ATTR, and all these other scenarios where they felt echocardiography could be performed first with further imaging based on the results. So I want to now conclude and provide my concluding thoughts on diagnostic evaluation of cardiac amyloidosis. Using imaging, we now recognize that as many as 13% of older patients hospitalized with heart failure can have coexistent transthyretin cardiac amyloidosis with heart failure with preserved ejection fraction. In studies which looked at transcatheter aortic valve replacement, as many as 18% of patients with severe aortic stenosis undergoing TAVR were felt to have coexisting transthyretin cardiac amyloidosis. That percentage was smaller with surgical AVR. All in all, this disease is emerging to be explaining a good proportion of HFpEF in older adults. We now have treatment for this disease. Tafamidis is an FDA-approved therapy. It was tested in a phase 3 double-blind placebo-controlled study of 441 patients with transthyretin cardiac amyloidosis, randomized in a 2:1:2 fashion to tafamidis 80 milligrams, 20 milligrams to placebo. Here's a survival curve from that study showing that all-cause mortality was significantly improved in the tafamidis group compared to the placebo group. However, when you look at the subset analysis of this, what the investigators found was that in patients who had class 1 or class 2 NYHA heart failure, they had a survival advantage from treatment with tafamidis, whereas patients with class 3 heart failure did not appear to have a survival advantage. This is being interpreted by experts at this point that early diagnosis of transthyretin cardiac amyloidosis and early therapy may lead to survival advantage, and advanced disease may be at a stage where it's beyond a point of no return and therapies may be less effective. So transthyretin cardiac amyloidosis was a rare and fatal disease that once needed endomyocardial biopsy for diagnosis. Bone avid scintigraphy studies have shown now that biopsy can be avoided and a specific diagnosis can be made. Initial therapies were symptomatic therapy, looking at avoiding ACE inhibitors, calcium blockers, beta blockers, and digoxin, and treatment of heart failure. But we now have targeted therapies using TTR silencers, TTR stabilizers, or tafamidis, and now also under investigation are amyloid fibril degraders. Epidemiological studies using bone avid scintigraphy have now shown us that this disease is no longer rare. It may be impacting almost 13 to 18% of older patients with HFpEF, and most importantly, this condition can potentially be now treated with some of the newer treatments. Because of all of this, I think the focus now on imaging ATTR cardiac amyloidosis is appropriate and well suited, and the future looks bright for preventing heart failure from this condition. Thank you very much for your attention.
Thank you very much, Dr. Sharmila. It was, as usual, a fantastic presentation. We can't ask for anything better from anyone in the globe. It was really great. We have time for questions now. So, Dr. Madhur has asked a question on the chat box. When can be technetium 19 PYP be false positive?
Yeah, no, that's an excellent question. So when can it be false positive? So we had a beautiful case recently. So let me go back historically. If you look at historically, PYP was developed in the early 1970s to image myocardial infarction or myocardial injury, right? This was a tracer to identify myocardial injury before we had CPKs and troponins. So this uptake in the myocardium can represent myocardial injury. So patients with acute myocardial infarction within the last 6 months, not really acute, but acute or subacute MI, can demonstrate false positive results. Some of these are regional. They're unlikely to be diffuse uptake as you have seen in amyloid, but regional uptake, please make sure the patient doesn't have history of myocardial infarction. There have been rare reports of PYP uptake related to hydroxychloroquine toxicity. This is drugs that are used in some of the connective tissue disorders, rheumatologic disorders, and there's been a case report or two from Mayo Clinic showing that you can have grade 2 PYP positivity in some of these patients. Now, if you look at the literature, people have talked about, rib fractures and others. Yes, you can see focal uptake of PYP in rib fractures, but that doesn't really impact myocardial activity on the SPECT. Planar imaging can be a problem, but SPECT imaging really does not impact. So the major thing in my mind would be myocardial infarction for a false positive. Okay, I see here one more question. C11 PIB or florbitapir, is it the best choice if available? Very good question. I think PIB and florbitapir have certain advantages, which is their pan-amyloid imaging tracers. So basically, if you perform PIB or florbitapir, you're likely to pick up both AL, ATTR, and even other rare forms of amyloid, and typing still needs to be performed after that. However, these tracers are not widely available and require access to a PET scanner. So the data at this point is limited for PET tracers in transthyretin cardiac amyloid. Therefore, I would say at this point, bone avid SPECT tracers with SPECT CT and quantitation are probably superior until we have more information. And here there's another question. It says, how do you compare ECV and T1 mapping with PYP in sensitivity and specificity? I think that's an excellent question. We don't have a precise answer for that. There have been some studies from the London Amyloidosis Group, the National Amyloidosis Center, which show that PYP activity may be related to ECV and T1. But remember, so far, quantitative PYP was not performed. So we were looking at visual grade 1, 2, 3, 4, looking at ECV or native T1 mapping in those cases. But now that we have quantitation, what we may find is a continuous measure of PYP activity may correlate well with a continuous measure of ECV and T1. So in terms of specificity, we think that the PYP or the bone avid tracer signal may be more specific for amyloid, because ECV, particularly lower levels of abnormality, let's say normal ECV upper limit is about 0.32 or 0.33. So the ECV is 0.34, 0.35, 0.36 in that range. It could be seen in any other forms of cardiomyopathy. It doesn't have to be amyloid. Non-ischemic cardiomyopathy, hypertensive heart disease, hypertrophic cardiomyopathy. Now, ECV over 0.40 is usually uncommon in most other conditions and is likely more specific for amyloid. So what I would say is ECV is a highly sensitive signal. It can detect early disease, and native T1 tissue characteristics also probably provide an important tissue marker for amyloid infiltration. But for early disease detection, there may be challenges because it can overlap with other forms of cardiomyopathy. All right, I'm not seeing any other questions here.
There are no other questions. Probably it was so clear and lucid that people don't have any questions. It was really, obviously it was so. It was really great having you, Dr. Sharmila. Ishwar, you want to take over, Ishwar?
Yeah, if anyone else wants to comment from the nuclear medicine side.
Dr. Madhur?
Dr. Madhur is there? Yeah.
Yeah, sir, I'm here. Sir, can you hear me?
Yeah, please go ahead.
Yeah, it was an excellent talk, Sharmila ma'am. I am basically working with Kavita ma'am in Nizam Institute of Medical Sciences, and we regularly do this amyloid imaging with PYP, and we found it extremely helpful. Though, as you told, initially we were doing a little earlier scans. That's why we had a few difficulties, but afterwards, 3 hours. So now we are getting excellent results. And this very good point you told me that AL amyloidosis, maybe we might not pick with PYP imaging, because there were 2 or 3 cases. Recently also there was one case in which the cardiologist, he was very sure that it is amyloidosis. The patient had rheumatoid arthritis for a long time, but we were not able to pick up. Like PYP was negative. So we were clueless. So then maybe the cause might be an AL amyloidosis. So it was really a very good, very nice talk, ma'am. Thank you very much.
Thank you. Yeah, so with rheumatoid arthritis and other forms of chronic inflammatory diseases, there is another form of amyloidosis called AA amyloidosis. And again, the SPECT tracers may be better to pick up AA compared to PYP or some of these bone avid tracers. So I would say for AA, the SPECT tracers will be better. But I'm really happy to hear that you're doing this. I think the huge advantage of bone avid tracers is they're widely available. SPECT technology is widely available. So this is something that most centers can offer. And with treatments becoming available, this may get to the stage in heart failure where most patients with heart failure, we try to exclude epicardial coronary disease or ischemic heart disease as a treatable cause of heart failure. I think we are headed in that direction that if you have heart failure with preserved ejection fraction, we're getting to a point where we want to exclude a treatable cause of HFpEF, one of them being amyloidosis. And the test is so simple and if performed right, can provide useful information.
Yeah, thank you, Dr. Madhur. Any questions from the other audience? Any nuclear medicine physicians in the audience? If you'd like to share your thoughts.